Now let's talk about clinical manifestations of ankylosing spondylitis. Now, what are the clinical manifestations? Now, these include, first of all, fever, that the patient will present with a low grade fever. Patient will also present with fatigue along with lethargy or some malaise. Patient will present with pain in the jaw. Now, the pain in the jaw is because the jaw or the temporomandible joint is sometimes also affected because it is near the axial skeleton. We sometimes also have the uveitis or the eye redness and inflammation. And anterior uveitis is found in about 40% of all patients, in all patients with their manifestations. And anterior uveitis is of special importance because this is the only clinical manifestation which is found to be antecedent to the actual disease, that it starts to happen even before the ankylosing spondylitis has started to present itself. So anterior uveitis is of extreme importance. Next, we have the pain in the rib cage, and this pain in the rib cage, which is usually of bony type, it is not of the muscular type, it is of the bony type, again, is due to the inflammation of the costo joints, and these joints are inflamed usually because of their proximity to the axial skeleton. So sometimes these joints also get inflamed along with the inflammation of the axial or the peripheral joints. Next, we have chronic pain and stiffness in lower back. Now, this is the complaint which with the patient usually come for. They come with pain that is chronic, that is happening for more than 3 months or 3 years, and they also complain of stiffness in the lower area, at the lumbosacral area. Now, this stiffness at the lumbosacral area is again due to the sacroiliitis and the resulting formation of the syndesmophyte. Because of this fusion of the bone or the vertebral column and the sacroiliac joint will result in loss of the both movement and range, resulting in stiffness. Next, we have the diarrhea, bloating, and the other gastrointestinal symptoms. Now, these symptoms usually present in ankylosing spondylitis due to the introduction of some kind of bacterial enterotoxin, and this enterotoxin results in increased GI symptoms. And sometimes these symptoms are so severe that the ankylosing spondylitis may start to represent itself in a subcategory which is known as the enteropathic ankylosing spondylitis. Next, we have the alternating buttock pain. Now, this alternating buttock pain is due to the ossification and the inflammation of the sacroiliac joint. Because the sacroiliac joint is usually in the process of ossification, the pain at that area usually alternates as the person moves and during the daily activity. Next, we have the psoriasis. Again, psoriasis in ankylosing spondylitis is of special importance, just like diarrhea and GI symptoms, because it can get so much expensive during the course of the disease that sometimes we also get a subcategory of ankylosing spondylitis known as the psoriatic ankylosing spondylitis or the psoriatic spondylitis. Next, we have the pain in the heel and the foot. Again, this is due to the inflammation of the tendon, usually the tendon of the calcaneum, that is known as the Achilles tendon. Now, this tendon, due to the anesthetitis, results in the pain at the area of the heel, or maybe sometimes the whole foot. And the whole foot is inflamed again due to the anesthetitis. Next, we're going to talk about the common complications which are present in the clinical setting. That is, patient present with the dull pain. So the pain is usually dull. It is not sharp, it is not pinching, it is of dull origin. So the patient usually cannot pinpoint the origin of the pain. They usually say that this lower back area is the one which is complaining of pain. Next, we have the insidious onset of that pain. Now, with insidious onset, we mean that the onset of the pain is sudden and without cause. And usually it happens even without the knowledge of the patient. Now, what it means is that the pain which has dull origin in the lower back, its onset is so sudden that the patient usually has no idea that why it is happening. They're usually confused about it. So such an onset of pain is known as an insidious onset. Next, we have morning stiffness of the lower lumbar tract. Now, morning stiffness is a hallmark of ankylosing spondylitis because patient wake up with morning stiffness, and morning stiffness is usually more than half an hour and may result up to 3 to 4 hours. And another good feature of ankylosing spondylitis diagnosis is that with activity, the morning stiffness starts to disappear. We also get bony tenderness. Now, these bony tenderness usually is found at the site of the spinal processes of the vertebral bodies, of the vertebra, at the greater trochanter of the femur, at the tuberosity of the tibia. So all of these bony areas or protuberances start to show tenderness, that they have pain when they are touched. So these bony tenderness, along with the formation of increased tenderness at the site of the vertebral column, is usually a good sign of ankylosing spondylitis, that some kind of fusion or ossification has started to take place. Next, we have severe hip arthritis. Now, hip arthritis or sacroiliatis, like I said, is a hallmark of ankylosing spondylitis, found in almost all of the patient. And when it's found in almost all of the patient, the hip pain or the hip arthritis is usually of the severe kind. Next, we have bony chest pain. As I mentioned earlier, pain in the chest or the rib cage is a good sign of ankylosing spondylitis, but that pain is not of constrictive type, it's not of muscular origin, it is of bony type, that you feel that there's some kind of dull pain in the bones near the sternum or at the junction with the vertebral column. Next, we have the juvenile onset. Now, juvenile onset is important because, as mentioned in the epidemiology, that ankylosing spondylitis usually starts during the second or the third decade of the human life. It does not start at the early decades. So, juvenile onset is of special importance. Why? Because during the juvenile onset, the ossification or the joining of the joints is usually at the peripheral areas, which then moves to the axial areas. And another important point is that a juvenile onset ankylosing spondylitis is of more severe kind because it starts from the periphery to the central skeleton. The severity of the inflammation is more marked at the periphery, resulting in reduced quality of life for the patient. Next, we're going to talk about the severe complications which might be presented in a clinical setting. Now, one of the most common complication of ankylosing spondylitis, which happens in about more than 10% of all patients, is the fracture of the vertebral column. Now, this fracture of vertebral column is common because one, the vertebral column has lost its flexibility because of the formation of the syndesmophyte. And syndesmophyte, when it is ossified, because of the introduction of more ossified elements, also results in osteoporosis, resulting in brittle syndesmophyte. All of these factors contribute to the formation of a fused vertebral column that is also brittle and more prone to fracture. And a fracture fused vertebral column can also have some other um, severe complications such as damage to the spinal nerves, damage to the abdominal structures, damage to the liver, stomach, sometimes even diaphragm or the pleural area. Sometimes they might even puncture the lung. Why? Because whole of the vertebral column has started to ossify, it can result into pointed projections which might pierce the internal viscera and organs. So a fracture is of severe complication. Next, we have the anterior uveitis, or the inflammation of the anterior uvea of the eye. Now, this again is important because if left untreated, will result in either partial or complete loss of the vision of the patient. And another good point which accompanies this is that it happens sometimes even before the fusion of the vertebral column, that it is antecedent, it happens beforehand. All of the complications and even the symptoms of the ankylosing spondylitis. So, because of its severity, that it might cause partial or complete blindness, is considered a severe complication. Next, we have the ischemic bowel disease. Ischemic bowel disease is a complication and it results in ulcers, um, sometimes venous ulcers, resulting in both the melena or sometimes even frank bleeding during defecation. And patient also complains of alternating between the constipation and diarrhea. And all of this starts to happen because of the ischemic bowel disease, along with uh, ankylosing spondylitis, have the same pro-inflammatory components. So, ankylosing spondylitis in a chronic setting can cause an inflammatory bowel disease. Why? Because they share the same common inflammatory elements. Now, if ischemic bowel disease is more pronounced in a patient with ankylosing spondylitis, it is termed as an enteropathic ankylosing spondylitis. Next is the psoriasis. Psoriasis is the appearance of white fish-like scales over the skin. Now, this can be limited or it can be diffuse, or diffuse as in it can appear over whole of the body in a patchy formation. Now, this can be a severe complication because it can result from the limited to the diffuse kind. And if it goes to the diffuse kind, it has to be treated along with the ankylosing spondylitis. And such a presentation is also termed as psoriatic ankylosing spondylitis. Next, we're going to talk about the physical examinations that we might perform in a patient with suspicion of ankylosing spondylitis. Now, one of those is called as the Schauber's test. In Schauber's test, patient complaining of dull pain with lower back stiffness is asked to stand straight up with the heels joined together and 2 points are marked. Now, these 2 points which are marked are this area where the iliac crusts of the patient are joined together and 10 centimeter above that point. Now, after the marking of these two lines, the patient is asked to bend over or to asked to have the flexion of the vertebral column. Now, if the length between these 2 points is less than 5, then the patient does not have ankylosing spondylitis. But if the length has not decreased less than 5 centimeter or is equal to or more than 5 centimeter, then our suspicion for ankylosing spondylitis increases. Another test that is usually performed is the chest expansion test. Now, chest expansion test is simple to perform. What we do is that we take the measurement of the patient's chest at the area where both the sternum and the manubriae come together. At that area, we take a measurement of whole of the rib cage and ask the patient to take a deep inspiration. Now, if that deep inspiration is having expansion more than 4 centimeters, it is considered normal. But if that expansion is less than 4 or is equal to 4, then again, suspicion for ankylosing spondylitis is increased and is considered among the differential diagnoses at this point.